Good morning. Myself Dr. Vani from Department of Pharmacology. I'll be taking a lecture on sulfonamides. So sulfonamides are the first group of antibacterial agents which are effective against treating microbial infection, which are both gram-positive as well as gram-negative infections. So coming to the history, sulfonamide was discovered by a scientist called as Domet. He found out that from a dye called as prontosyl red, from where the byproduct of prontosyl, which is a sulfanilamide, that derivative had an antimicrobial action. That is how sulfonamides were derived. Coming to the objectives. So the objectives of this session includes, at the end of the lecture, you will be able to understand what are the drugs available in sulfonamides, what is the mechanism of action of sulfonamides, what is the role of combination therapy in sulfonamides with trimethoprim and pyrimethamine, what are the therapeutic uses of sulfonamides, what are the adverse effects and contraindications of sulfonamides, drug interactions, and these special conditions where sulfonamides are used. Coming to the sulfonamides per se. So sulfonamide, as I already told you, the history of sulfonamide is it was derived from a diprontosyl red, but it was discovered by the scientist called as Domet. So in your next exam, they can ask this question in the history perspective of pharmacology as well as microbiology. So he found out that this prontosyl red byproduct has a antibacterial action against streptococcal infection. That is how these sulfonamides were derived. So sulfonamides are effective for treating both gram-positive as well as gram-negative infections. So currently these drugs are used for treating gram-positive and gram-negative infections as a second-line drug, and it is used in combination therapy for treating respiratory tract infections and urinary tract infections. Coming to the derivatives. So what are the drugs available in sulfonamides? So based on the duration of action, sulfonamides are divided into short-acting drugs. So the short-acting drugs are sulfasalazole and sulfadiazine, which has a shorter duration of action of 4 to 8 hours. That is, the drug will stay in our body for 4 to 8 hours. After that, the drug will get eliminated from our body. So one major good point about this short-acting drugs are they are less plasma protein bound, and it has a property to cross the barriers. That is your blood-brain barrier and blood CSF barrier and blood placental barrier. So in case of this drug crossing the blood-brain barrier, it can be used for treating recurrent meningitis infection. That is, in case of chronic meningitis, we can use this drug as a reserve drug or second-line drug. And you will be coming across this term called as crystalluria. Crystalluria is nothing but passage of sulfonamide crystals in urine. We call it as crystalluria. So how these crystals are passed in urine? Your sulfonamide is metabolized by the phase 2 metabolism. We call it as acetylation. So by the acetylation process, your sulfonamide is broken into smaller particles. These smaller crystals, when they are excreted in urine, they form a crystalluria. That is passage of sulfonamide crystals in urine. We call it as crystalluria. So one major concern about sulfonamide usage is this crystalluria. Coming to the intermediate acting drugs. So the intermediate acting drugs includes sulfamoxazole and sulfamethoxazole. The duration of action of intermediate acting drugs are 8 to 12 hours. This drug is used in combination with trimethoprim. So we have a fixed drug combination, that is FDC, cotrimoxazole. So your cotrimoxazole can be asked as a separate short note in your university exam. So make sure you read about this for your final exams as well as your IAs. So cotrimoxazole is combination of sulfamethoxazole and trimethoprim. So why these two drugs are combined? When these two drugs given as a single drug or single agent, this drug produces static effect. When these two drugs are combined, this drug produces sidal effect, and it prevents the further multiplication, and it also kills the existing bacteria. So that is how it is producing a good antibacterial effects. That is why these drugs are used in combination therapy. Currently, we have a fixed dose regimen of these drugs. Coming to the long-acting drugs, which has duration of action of more than 12 hours, the drugs are sulfadoxine and sulfamethoxypyrazine. So the main concern of your longer acting drugs are these drugs are highly plasma protein bound and has slower renal excretion. So for the people who have a renal compromise or who are in early stages of renal failure, your longer acting drugs are completely contraindicated. Okay, so where all your longer acting drugs are used, it is used for treating malaria, toxoplasmosis, pneumocystitis in combination with pyrimethamine, and it is also used for treating your lower respiratory tract infections as well. Coming to sulfonamide as an antibacterial agent. So how your sulfonamide act as an antibacterial agent? Your sulfonamide causes antibacterial effect by inhibiting the folate synthesis in the bacteria. So bacteria requires folic acid for development and maturation. Your sulfonamide inhibits this byproducts by inhibiting the folic acid synthesis and reductase enzymes. So your para-aminobenzoic acid antagonizes the action of sulfonamide. First cells are rich in PABA, that is your para-aminobenzoic acid. That is why your sulfonamides are effective in bacterial infections because your first cells are rich in PABA. Your drug goes and inhibit the enzymes which are effective for converting PABA into dihydrofolic acid and tetrahydrofolic acid. Okay, so your prilocaine, which is a local anesthetic, releases para-aminobenzoic acids and reduces the sulfonamide action. So this can be considered as a drug interaction. Okay. Coming to the proper mechanism of action, as I already told you, sulfonamide inhibits the folic acid from para-aminobenzoic acid. That is, it inhibits the synthesis of folic acid from para-aminobenzoic acid. So the sulfonamide is a structural analog of para-aminobenzoic acid, which inhibits the enzyme dihydrofolic acid synthase. Whereas your dihydrofolic acid is formed with the help of enzyme dihydrofolic acid synthase, whereas your tetrahydrofolic acid is formed with the help of your enzyme dihydrofolic acid reductase. So you need dihydrofolic acid synthase for the formation of dihydrofolic acid, and you need dihydrofolic acid reductase for the formation of tetrahydrofolic acid. Your tetrahydrofolic acid, what it does is it goes and stimulates the nucleic acid synthesis. So, and there will be synthesis of RNA, DNA, and proteins. So this is a pictorial representation or flowchart representation of your synthesis of folic acid from PABA and how your drug is getting acted. See? Yeah. So from your dihydropteridine, when combined with para-aminobenzoic acid, dihydroteroic acid is formed. Your dihydroteroic acid gets converted to dihydrofolic acid with the help of enzyme dihydroteroic acid synthase. Whereas your dihydrofolic acid gets converted into tetrahydrofolic acid with the help of enzyme dihydrofolate reductase. So your sulfonamide inhibits this step, conversion of para-aminobenzoic acid into dihydrofolic acid by inhibiting this dihydrofolic acid synthase or dihydroteroic acid synthase. So when this tetrahydrofolic acid is formed, this goes and stimulates your nucleic acid bases as well as amino acid, which in turn forms RNA, DNA, and protein synthesis. See, your sulfonamides are inhibiting this conversion of para-aminobenzoic acid to dihydrofolic acid. And we already came with the examples, sulfonamides, sulfamethoxazole, sulfadiazine, and sulfadoxine. So as I already told you, there are some drugs which are used in combination with sulfonamide. The drugs are trimethoprim and pyrimethamine. Your trimethoprim is an antibacterial agent, whereas your pyrimethamine is an anti-malarial agent. So when these drugs, how does it act as an antibacterial or anti-malarial agent is it inhibits the dihydrofolate reductase enzyme. So if in Viva, if they ask you about the mechanism of action of sulfonamide, you have to tell them your sulfonamide inhibits the folic acid synthesis by inhibiting the enzyme dihydrofolic acid synthase, which is a key step for formation of dihydrofolic acid. So it inhibits the conversion of para-aminobenzoic acid into dihydrofolic acid. Whereas your cotrimoxazole and your antimalarial effect of pyrimethamine gets with inhibiting the enzyme dihydrofolate reductase, which is a keystone for formation of tetrahydrofolic acid. So this can be asked in Viva. This can be framed as an MCQ. So if they are framing this MCQ, they'll be giving all the following are correct except. So if they give that exception part, they might give you this glutamate or this dihydrotyridine part. So if they give this, you have to tick correctly as dihydrofolic acid synthase or reductase as the answer if they are asking which is correct. If they are asking which is wrong, then you have to go for other answers as well. Yes, and one more point is when, as I already told you, when these drugs are given individually, these are static in nature. So bacteriostatic are the effect which occurs, the drugs which prevents or which arrest the growth and multiplication of organisms, we call them as bacteriostatic agents. Whereas the drugs which kills or which prevents the further development and maturation of the organism and which kills the existing pathogen, we call them as bactericidal agents. So when used in combination, these drugs become bactericidal in nature. See in the picture? Yeah. So your PABA to dihydrofolic acid inhibited by your sulfonamides. When these are given as a single drug therapy, they are static. When used in combination, your cotrimoxazole and cotrimazine, they become cidal. Coming to the spectrum. So these drugs are primarily bacteriostatic in nature. It is used for treating both gram-positive as well as gram-negative infections. So the examples of gram-positive infections include Staphylococcus, Streptococcus, and Pneumococcus. Examples for gram-negative infections include your Klebsiella, E. coli, Salmonella, Shigella, and Pseudomonas. So for all these infections, your sulfonamide acts as a second-line drug or alternative drug therapy. So then while reading about antimicrobial agents, you have to read about basically five things. You should read about how it is derived, what are the drugs available, mechanism of action, then spectrum, then comes the resistance. Resistance plays a major role because currently now we are facing antimicrobial resistance. So this was developed due to misuse of antibiotics. So to prevent that, if you know the resistant part, you can modify the usage. So for this only now the WHO has introduced this aware classification of antibiotics where A stands for access group, W stands for watch group, and R stands for reserve group. Whereas your sulfonamide comes under reserve group. Okay. Access group as well as reserve group. For higher end infection, it is used as in reserve group. For acute infections and recurrent infections, it is used as an access group antibiotic. Okay, so here coming back to the topic, sulfonamide resistance. So we already told para-amino benzoic acid plays a key role for the synthesis of your folic acid. So if there is increased production of para-amino benzoic acid, this can also cause drug failure. Coming to folate synthase affinity. So if the affinity of your folate synthase enzyme is less, even in that case, there can be decrease in folic acid synthesis that can also cause drug failure. So if there is less affinity of your enzyme, where your sulfonamides goes in that can also cause drug failure. Coming to the third point, adoption of alternate pathway. Instead of depending upon this para-amino benzoic acid, if the bacteria adopts alternate pathway, even in that case, patient can develop resistance. Coming to pharmacokinetics, this drug is well absorbed orally. It has higher plasma protein binding property. We already saw your short acting drug has less plasma protein binding property, and the longer acting drugs will have a larger volume of distribution as well as higher plasma protein binding property, and it also has longer duration of action. I already told you this drug will cross the meninges, blood CSF barrier and blood-brain barrier. Hence, it is used in treatment of meningitis. Since it crosses the placenta, it can cause teratogenic effects in the baby. Hence, it is contraindicated in pregnancy. Once the mother confirms pregnancy, she should not consume certain drugs. So, your sulfonamide comes under category X drug of pregnancy. Okay. Coming to the third part, metabolism. I already told you the drugs get metabolized by phase 2 metabolism of enzyme with the help of acetylation process by microbial acetyl transferase. So after getting broken down, these drugs gets excreted in urine in the crystal form. That is why we get crystalluria as a side effect of sulfonamide. Okay. Coming to the adverse effects. This is what one important Viva question. They can ask you in Viva what are all the major side effects of sulfonamide which limits the usage of sulfonamide. So the side effects profile include crystalluria, dose related because based on the dose, if you are giving a shorter acting drug in a lower dose, it doesn't cause much crystalluria. But if you are giving a longer acting drug at a higher dose, this drug can cause crystalluria, which is dose dependent. So if a patient is having crystalluria, then there can be a next question, what you'll do, how you'll treat it. So for this patient, we'll be replacing them with IV fluid and will also alkalinize the urine. When the urinary pH is alkalinized, these crystals get dissolved and it gets passed in urine. So that can be done with alkalinization of urine with sodium bicarbonate. Okay, coming to the second important adverse effect, fixed drug reaction, that is fixed drug eruption. We call them as a Steven-Johnson syndrome, which is a tumor lysis syndrome, which is developed due to intake of drug by the patient who are having this sulfur-related group of allergy. So this patient might already have a sulfur drug allergy. They may not be aware of it. When you are giving this drug, it can present as a delayed hypersensitivity reaction type 4. We call it as a Steven-Johnson syndrome. What are the other side effects? All the sulfur group of drugs will have hypersensitivity reaction. Majority of the antibiotics patient might have hypersensitivity reaction as well as allergy. So make sure before giving any antibiotic in the IV route, take history of drug allergy, give test dose. Once you confirm the patient doesn't have an allergy or patient doesn't develop any rashes post test dose, you can proceed with the drugs. If you are seeing the patient is developing any rashes in and around the injection site, you are not supposed to give the antibiotic. So make sure before giving any antibiotic in the intravenous route, make sure you are doing first dose. Okay. Coming to the other adverse effects, photosensitization, hepatitis, contact dermatitis. In patients who are already suffering from G6PD deficiency, this is one among the drug which can cause hemolysis. Hemolysis is nothing but breakdown of your blood cells. So it causes excess breakdown of blood cells which can end up in hemolysis, and it can also cause kernicterus in premature infants. So kernicterus is nothing but inflammatory meninges. It is a condition of inflammation of meninges which occurs due to raised bilirubin levels. So, for example, if the mother has taken sulfonamide in the third trimester, the baby might be born as premature baby, and the baby might suffer from this kernicterus, which is a inflammation of meninges due to raised bilirubin levels. So that is why we always tell antibiotic usage should be used only whenever required. Especially in pregnancy, antibiotics are avoided unless required under the supervision of gynecologist and general medicine physician. We are not supposed to take antibiotics in pregnancy. Coming to the explanation of a fixed drug eruption. So usually fixed drug eruption develops within 30 minutes to 8 hours of taking drugs. There are sometimes the patient might not develop it immediately, but the patient might develop in a later stage. In Stevens-Johnson syndrome, the patient develops a reaction at a later phase. Okay, so where all you can see this lesions. So the lesions are seen around the limbs, around the mouth, eyes, genitalia, and perianal and perioral region. Okay, so once the lesion starts healing, it can form crest and scaling followed by brownish discoloration at the site. So wherever the lesion has developed, the patient might have a brownish discoloration around those sites. Okay. The fixed drug reaction can also occur at the same site, because that is why we call them as fixed drug eruption. So, for example, previously the patient might have taken any sulfamethoxazole or sulfadiazine. The patient might develop a reaction some 1 month back. After that, again, the patient is consuming the same sulfonamide. The patient will develop the same reaction at the same site. So, for example, 1 month back, she developed a perioral discoloration. Again, after 1 month, if she consumes the same tablet, she might develop the same perioral discoloration. That is why the name is fixed drug reaction. It occurs at the same site on each exposures. Coming to what are the other drugs which can cause fixed drug eruption is, in sulfonamide, we have 3 drugs which can cause fixed drug eruptions: trimethoprim, sulfonamide derivatives, as well as your cotrimoxazole. And the other antibiotics include fluconazole, ciprofloxacin, doxycycline, and clarithromycin. Your painkillers like NSAID, your anti-epileptic drug like phenytoin, and your antihistamine like cetirizine, and your anti hypertension drugs like pseudoephedrine can also cause fixed drug eruption. See, this is a pictorial representation of fixed drug eruption. In this picture, you can clearly see the patient is having a bluish brownish discoloration around his arms. See, around his arms. See, around the lip, the patient is having discoloration. Even on the lip, you can see this discoloration. So this is how the patient will have this discoloration every time on exposure to sulfur drugs. You can clearly see it now. See. So coming to the explanation of Stevens-Johnson syndrome. So Stevens-Johnson syndrome is a toxic epidermal necrosis. So the epidermis of the patient is completely destroyed due to drug intake. which is associated with a minimal level of inflammation. So this reaction is idiosyncratic. So we don't know whether who will develop this reaction, and it is a type of delayed hypersensitivity reaction, which is a type 4. So it is not present immediately. It will be presenting at a very late stage, maybe after 1 day or 2 day, maybe after a week, or maybe after some 6 months of drug intake. Okay, so who is commonly affected with the Stevens-Johnson syndrome? So there are a few genotypic patients who we call them as a slow oscillators. So basically, population is divided into three parts: slow oscillators, intermediate oscillators, and fast oscillators. Slow oscillators are the patient who will have a less drug metabolizing enzymes. Intermediate oscillators will have a required amount of drug metabolizing enzymes, whereas fast oscillators will have excess of drug metabolizing enzyme. So for the slow oscillators group, they have a very less drug metabolizing enzyme, so which in turn causes reduced plasma excretion of the drug, so which in turn causes drug accumulation in the body. That is where your toxicity develops. One common type of toxicity is the Stevens-Johnson syndrome. For intermediate acetylators, the patient will have a proper enzyme, so the absorption excretion is equilibrium. Whereas for fast accelerators, the drug metabolism enzyme is higher rate, so they will have metabolism at a faster rate. So for fast accelerators, we have to increase the dose of the drug. Okay, so this is one point you should know about the genetic part of the drug. So this comes under pharmacogenetics. Okay, so who all can develop this Stevens-Johnson syndrome? Immunocompromised patients, patients with brain tumors who are undergoing radiotherapy with concomitant anti-epileptic drugs, because we already saw phenytoin can cause Phenytoin can cause Stevens-Johnson syndrome. We already saw this sulfa group of drugs can cross your blood-brain barrier. Since the patient who are undergoing chemotherapy and radiotherapy, they can also develop this Stevens-Johnson syndrome. So if they ask you about examples of drugs causing Stevens-Johnson syndrome, you should tell them in detail. Okay. So, the patient with sulfonamide induced toxic epidermolysis have shown to be a group of slow oscillators genotype that result in increased production of sulfonamide hydroxylamine. So, this byproduct sulfonamide hydroxylamine causes this Stevens-Johnson syndrome. So, these drug metabolites have a direct toxic effect and may act as a hapten. So, hapten is nothing but the agent which induces the immune response. So, this agent can act as a hapten which can affect the host immune response. And that is how they become antigenic, and they can cause this epidermal lesions. See, this is one picture of Stevens-Johnson syndrome. See, you can see the discoloration of the skin even as well as around her nose and a little on the lips. See, discoloration around the lips, on the lips. And this is the picture of kernicterus, that is inflammation of brain in the premature baby. Coming to the other list of drugs which can cause Stevens-Johnson syndrome, I've already given you the list. These are the other group of drugs: allopurinol, barbiturate. All your majority of your antiepileptic drugs can cause Stevens-Johnson syndrome. Valdecoxib, levofloxacin, diclofenac, isotretinoin, fluconazole, sitagliptin, vancomycin, pyrimethamine, and cefixime. So all these are the list of drugs which is causing Stevens-Johnson syndrome. So they can ask you in Viva, name some drugs which causes Stevens-Johnson syndrome. So make sure you tell about these drugs list. Coming to the drug interaction part. So when these drugs are, I already told you these drugs have a higher plasma protein binding property based on their duration of action. So hence this drug has plasma protein binding property. When it is given along with a drug which has a similar plasma protein binding property, the sulfonamide will inhibit the binding of the secondary drug. So your sulfonamide is a primary drug, whereas the second drug, which is also having a plasma protein binding inhibiting property, when these two drugs are combined together, when given together, sulfonamide will inhibit the plasma protein binding property of the second drug. For example, when sulfonamide is given along with warfarin, warfarin also compete for the same plasma protein binding, that is your plasma alpha 1 globulin and albumin. So warfarin 90% binds to albumin and rest of 5 to 10% binds to alpha 1 glycoprotein. So your sulfonamide also competes for this same plasma protein, your albumin. Your sulfonamide will inhibit the plasma protein binding property of warfarin, which can cause warfarin failure. So the patient might have excess of bleeding. Your warfarin is an anticoagulant, so there might be excess of coagulation. The patient might present with bleeding. So this is one side effect which can be listed. That is why we should always make sure we should take history of drug allergy, should take history of drug intake before prescribing any drugs to the patient. Okay. So it also increases the concentration of other drugs like phenytoin, tolbutamide, and warfarin and methotrexate. So it displaces the plasma protein from the binding site, increases the concentration of other drugs like phenytoin, tolbutamide, warfarin, and methotrexate. Coming to cotrimoxazole. So cotrimoxazole, as I already told you, this drug, when given as a single drug therapy, it produces static effect. When cotrimoxazole is used in combination of sulfamethoxazole and trimethoprim, this drug produces sequential blockade. So sequential blockade is nothing but inhibiting both dihydrofolate synthase as well as hydroxylase in a stepwise manner. The stepwise manner of inhibition of enzyme, we call them as sequential blockade. So this cotrimoxazole is available in the preparation of 1 is to 5 and 1 is to 20. So why this 1 is to 5 and 1 is to 20 is preferred is your trimethoxazole has a larger volume of distribution, whereas your sulfamethoxazole has a similar T-half to trimethoxazole. That is why sulfamethoxazole is used in combination with trimethoxazole. Coming to the why sulfamethoxazole is preferred, I already told you sulfamethoxazole has a similar T-half of with the trimethoprim. That is why your sulfamethoxazole is preferred as a combination drug with trimethoprim. Why ratio of 1 is to 5 is trimethoprim has a larger volume of distribution, and based on the need of the patient, 1 is to 20 is also preferred. Why it is not harming human cells? Trimethoprim is sensitive for bacterial dihydrofolate reductase. That is why it is not affecting human folic acid synthesis. Because your human folic acid is already preformed. Your drug we can't go and affect the preformed folic acid. It prevents the further synthesis of folic acid in the bacteria. Coming to the spectrum of cotrimoxazole, as I already told you, it affects both gram-positive and gram-negative infections. Resistance part. So I already told you cotrimoxazole produces sequential blockade. Your sulfonamide inhibits dihydrofolic acid synthesis, whereas your trimethoprim inhibits dihydrofolic acid reductase. So if the affinity is reduced for dihydrofolic acid reductase, in that case, patient might develop resistance. Coming to adverse effect profile is similar to your sulfonamides like crystalluria, renotoxicity, as well as this drug can also cause hypersensitivity reaction and Stevens-Johnson syndrome. So this drug is producing renal toxicity, hence it is contraindicated in patients who are having renal failure. And it can also cause teratogenetic effect because it has antifolate enhancing effect. That is why it is contraindicated in pregnancy. So at the outset, your sulfonamide and cotrimoxazole are contraindicated in pregnancy. Okay. And it can also cause bone marrow depression in elderly. Hence, it is not preferred in elderly patient. Coming to drug interaction. So drug interaction part is similar to your sulfonamide. It can increase the plasma, it can displace the plasma protein binding property of the drugs which has higher plasma protein binding property. And when cotrimoxazole is given with diuretic, it has chances of producing thrombocytopenia. So this is one hint here. This drug, when given with diuretic, it can cause thrombocytopenia. So when C and T is combined, it produces T. CD causes T. That is your cotrimoxazole given with diuretic can cause thrombocytopenia. So these are the list of drugs which also has antifolate action, proguanil, pyrimethamine, methotrexate and trimethoprim. Coming to the uses of sulfonamide. So your sulfonamide and cotrimoxazole is used for treating facial-maxillary infection, respiratory tract infections, urinary tract infections, prostatitis, typhoid, bacterial diarrhea and dysentery, pneumocystitis infection in AIDS, chancroid, and Burns dressing. Coming to the drug of choice of cotrimoxazole. Cotrimoxazole is drug of choice for treating pneumocystitis, pneumonia infection, nocardia infection, and Yersinia enterocoliaceae infection. So it is used as a second-line drug in certain infections. All the gram-negative infections, your cotrimoxazole is used as a second-line drug for Salmonella, Shigella, E. coli, Vibrio cholerae, Brucella, and atypical mycobacterium. For all these infections, your cotrimoxazole is used as a second-line. So this is one mnemonic which I wanted you all to know. Sulfonamide today is used as a combination therapy. We already saw this in the initial slides. So your trimethoprim is the available combination is cotrimoxazole. It is used as an antibacterial agent for treating UTI and respiratory tract infection. Whereas your pyrimethamine, which is cotrimazine, is used for treating, is used as an anti-malarial agent. It is combined with a longer acting sulfonamide. Remember it as TB and PM. So your T is nothing but trimethoprim, is used as an antibacterial agent, whereas your P is nothing but pyrimethamine, which is used as an anti-malarial agent. So this is one point which you should know. Your sulfasalazine byproduct sulfapyridine and 5-aminosalicylic acid. Your sulfapyridine is well absorbed and it is useful in treating rheumatoid arthritis, whereas your 5-aminosalicylic acid is not well absorbed and it has an anti-inflammatory property in the gut. Hence, it is useful for treating inflammatory bowel disease like your Crohn's disease and ulcerative colitis. So these are the special mentions of sulfonamides. Your sulfacetamide is available as an ocular drop. Your mefenamide is active in pus and pseudomonas and it also produces severe burning sensation. That is why it is not commonly used. Your silver sulfur diazine is used as a topical applicant for burn dressing. So why silver sulfur diazine is used is the released silver ions prevent the further growth and multiplication of your anaerobic pathogen as well as gram-positive and gram-negative pathogens on the burns. So to prevent the development of bacterial infections in burns patients, your silver sulfur diazine is used as a material for topical application before doing burn dressing. And silver sulfasalazine, we already saw sulfapyridine 5-aminosalicylic acid. Sulfapyridine is used for treating rheumatoid arthritis, whereas 5-aminosalicylic acid is used for treating ulcerative colitis. So this is one short summary. Short-acting drugs, sulfadiazine, sulfasoxazole. Intermediate-acting, sulfamethoxazole. Long-acting drugs, sulfadoxine and sulfamethopyrazine. Special purpose, we already saw sulfacetamide eye drop, silver sulfasalazine for ulcerative colitis and silver sulfadiazine for treating burns. Yeah, so the important questions are classification of sulfonamide, mechanism of action of sulfonamide, we already saw. Advantage of cotrimoxazole, we already saw. When used as a combination therapy, these drug produces sidal effect. And sequential blockade, your cotrimoxazole is the drug which produces sequential blockade by inhibiting both dihydrofolate synthase and reductase. Uses of sulfonamide, we saw it is useful for treating gram-positive and gram-negative infection. It is also used for treating burns dressing and chancroid. Adverse effects, main adverse effects are crystalluria, Steven-Johnson syndrome, hypersensitivity reaction, and it can cause hemolysis in G6PD deficiency patients. So this is one case scenario which I wanted you all to know. A 54-year-old male patient came to the OPD with complaints of fever for more than 1 week and he has recent history of travel to Africa. On lab investigation, he is found to have falciparum-induced malaria. What could be the preferred drug? So falciparum malaria are chloroquine resistant. So in that case, you have to prefer the other drug therapy. So here we'll be preferring your sulfur cotrimazine. Your cotrimazine is nothing but pyrimethamine combination. We already saw no TB and PEM. So your sulfonamide with pyrimethamine combination is used for treating falciparum-induced malaria. So that's it for today's class. Make sure you are reading all correctly. You should read pharmacology daily. Pharmacology is all about understanding the concept and applying the concept in the practical day-to-day life. So make sure you are reading pharmacology and applying pharmacology in your day-to-day life. Thank you.